Hello and welcome back to Health Voices. I want you to forget everything you think you know about what causes a heart attack. For decades, we've been told a simple story that heart attacks are caused by high cholesterol, that it's a slow-moving sludge that gradually clogs our arteries over many years, like grease in a kitchen pipe. But what if I told you that story is dangerously incomplete? What if I told you that the number one cause of most fatal heart attacks in people over 60 isn't high cholesterol? The truth is, most deadly heart attacks are caused by something much faster, much more violent. A sudden, catastrophic event that happens inside your arteries, often with absolutely no warning at all. And the one common pill that can sometimes stop this event in its tracks, aspirin, is now the subject of so much fear and confusion that people are making life-or-death decisions based on news headlines, not on their own personal health. Today, we are cutting through all of that noise to get to the truth. And here to guide us is the expert we trust to handle these complex topics, cardiologist Dr. David Miller. Dr. Miller, thank you for being here to tackle what is clearly a very confusing and high-stakes issue for our audience.
Thank you for having me, Sarah. And you have just hit on one of the most critical and most dangerous points of confusion in modern medicine today. This pendulum of advice on aspirin, one day it's a miracle drug, the next day it's a poison. It has left so many people, especially seniors, feeling lost and unsure of what to do. And I want to start by saying this. Aspirin is not a one-size-fits-all drug. It is not good or bad. It is powerful, and the decision to use it or not to use it has to be one of the most personalized decisions in all of medicine. It must be based on your specific data, not on a general trend. To understand why, we have to understand what a heart attack really is.
That's exactly what I was hoping you'd explain. You said it's not just a slow clog. So, what is it?
That's right. I want you to forget the image of a slow clog for a moment. Instead, I want you to imagine a busy highway tunnel at rush hour. Traffic is flowing smoothly. Everything seems fine. But hidden on the wall of that tunnel, there's a small, unstable patch. Maybe a weak spot in the concrete. You can't see it. You can't feel it. Then one day, with no warning at all, that patch ruptures. It cracks open. Your body sees this rupture as an emergency, like a car crash, and it does what it's programmed to do. It instantly sends out its first responders, which are your blood's clotting cells, the platelets. They rush to the scene to form a seal, a blood clot, to patch the injury. Now, if this was a cut on your skin, that clot would save your life. But inside the narrow tunnel of a coronary artery, that helpful clot becomes a catastrophic roadblock. It can expand so rapidly that it completely blocks the entire highway in just minutes, or even seconds. The blood flow downstream stops completely, and the heart muscle that was being fed by that artery begins to die from lack of oxygen. That is a heart attack. It's not a slow clog. It is a sudden thrombotic event triggered by a plaque rupture.
That image of a sudden car crash inside an artery. It's so much more terrifying than a slow-moving clog. It really makes the urgency feel so much more real. So with that picture in mind, where does a simple pill like aspirin fit into that chaotic scene?
That's the perfect question, Sarah. Because to understand aspirin's role, you have to understand its true job. The first thing everyone needs to know is what aspirin doesn't do. Aspirin does not clean out your arteries. It doesn't dissolve old, hardened plaque. It's not a drain cleaner for your circulatory system. Its function is much more subtle and much more crucial in that moment of crisis. Think back to that car crash inside your artery. That plaque rupture. Your body's first responders are the platelets, the clotting cells in your blood. You can think of them like tiny sticky bricks. The moment there's an injury, they get a signal to rush to the scene and start piling up to build a dam or a blood clot. What aspirin does is it makes those little bricks less sticky. It interferes with their ability to clump together and form that dangerous artery-blocking dam so quickly. That's why I often tell my patients to think of aspirin like a fire extinguisher. You don't go around spraying a fire extinguisher all over your house just in case. That would make a huge mess and could even be harmful. But if a fire actually breaks out, that fire extinguisher is the most important tool you have. It can save your life. In this analogy, the plaque rupture is the fire, and aspirin is the fire extinguisher that helps to stop that fire from spreading and blocking off the whole blood supply.
A fire extinguisher for the bloodstream. That's a very powerful and clear analogy. So it's really an emergency response tool, not a maintenance tool.
Precisely. And that is why it is so critical, absolutely critical, to understand which group you fall into. Because in cardiology, we think about two very different situations for using aspirin. The first group is what we call secondary prevention. The word secondary means you have already had an event. You already have a known fire risk. This includes anyone who has ever had a heart attack, a stroke, had a stent placed in their heart, had bypass surgery, or has been officially diagnosed with atherosclerosis, which is hardening of the arteries. For this group, the evidence is overwhelming and has been for decades. For these patients, taking a daily low-dose aspirin is not a debate. It's not optional. It is one of the cornerstones of their treatment. Numerous studies, including some landmark trials published in the New England Journal of Medicine, have shown that for these high-risk patients, aspirin can reduce the risk of a second, possibly fatal event by up to 30%. For them, it is a life-saving medication.
Okay, so that's the first group. Secondary prevention. If you've had a previous event, aspirin is your ally. What's the second group? This must be where the confusion comes in.
This is exactly where the confusion comes in. The second group is called primary prevention. Primary means you are trying to prevent a first-ever event. These are people who have never had a heart attack or a stroke. On the surface, they seem healthy. This is the group that the recent guidelines have been talking about. Major large-scale studies a few years ago looked at this specific group, and what they found was that for people who are at a low risk of having a heart attack, the small but real risk of internal bleeding that can come with taking aspirin might actually be greater than the benefit of preventing a heart attack they were very unlikely to have in the first place. Because of that, the guidelines from the U.S. Preventive Services Task Force were updated. They no longer recommend that every single person over 60 just starts taking aspirin as a routine measure if they have no known heart disease. But here's the dangerous part. People in the first group, the high-risk secondary prevention group, they heard these headlines and thought the advice applied to them. And that can be catastrophic. I have a story that I think illustrates this perfectly, and I share it because I don't want to see it happen to anyone else. I have a patient, we'll call him Frank. He's 68 years old. 5 years ago, we found a significant blockage in one of his arteries, and he had a stent placed. He was a model patient. He took his medications, he exercised, and he took his 81 milligram baby aspirin every single day. Then one afternoon, he was reading an article online. The headline was something like, "Doctors now warn against aspirin for seniors." Frank is a smart guy. He thought he was being proactive. He thought he was following the latest science and making a healthy choice for his body. So without calling my office, he stopped taking his daily aspirin. For 3 months, everything seemed fine. He felt great. He was even a little proud of himself for taking one less pill every day. But one Saturday morning while he was out gardening, he felt that old familiar pressure building in his chest. It got intense, fast. His wife called an ambulance. He got to the emergency room just in time. The doctors found a new, dangerous blood clot was forming right near his old stent. He had a very, very close call with a major heart attack. We were able to stabilize him, but it was a terrifying wake-up call for him and his family. When I spoke to him in the hospital, he was so shaken. He looked at me and said, Doc, I don't understand. I thought I was doing the right thing. I thought the guidelines had changed for me. And I had to sit down and explain to him, Frank, those headlines, they were not talking about you. You are in the secondary prevention group. You have known heart disease. For you, aspirin isn't a maybe, it is your insurance policy.
That story is absolutely terrifying. And it's so easy to see how someone could make that mistake. You think you're being an informed patient, but you're applying the wrong advice to your situation. It really shows how critical it is to know which group you actually belong to. So that brings up the most important question. How does a person in that primary prevention group, someone who hasn't had an event, know if they're truly low risk like the guidelines talk about? Or if, like you said, they have a hidden fire waiting to start? That story about Frank is absolutely terrifying, Dr. Miller. And it's so easy to see how someone could make that same mistake. You think you're being an informed patient, but you're applying the wrong advice to your personal situation. It really shows how critical it is to know which group you actually belong to. So that brings up the most important question. How does a person in that primary prevention group, someone who hasn't had an event, how do they know if they're truly low risk like the guidelines talk about? Or if, like you said, they have a hidden fire waiting to start inside their arteries?
That is the most important question anyone in that group can possibly ask. And the answer to that question is the foundation of modern preventive cardiology. Here is the hard truth, and I want everyone listening very carefully to this. The most dangerous thing about heart disease is that in its early and even its intermediate stages, it is almost completely silent. You cannot feel plaque building up in your arteries. You can't feel your cholesterol turning into a dangerous lesion on the artery wall. There are no early warning signs. There is no little ache or pain that tells you something is wrong. In fact, and this is a sobering statistic, for up to 50% of people who have a fatal heart attack, the heart attack itself is the very first symptom they ever experience.
50%. That's a terrifying thought. It means you can't wait for a symptom to tell you that you're in trouble.
You can't. If you wait for the symptom of a heart attack, you may already be too late. So if you can't rely on how you feel, you have to rely on data. You have to be willing to look under the hood. And thankfully, modern medicine has given us some incredible, non-invasive tools to do just that, to see what's really going on inside. The single most powerful test I recommend for this situation, the one that has truly revolutionized how we assess risk, is called a coronary artery calcium score. We often just call it a CAC scan.
A CAC scan. Can you tell us what that is and how it works?
Of course, it's a very fast, completely painless CT scan of your heart. You just lie on a table for about 10 minutes. There are no needles, no dyes. And this scan does one thing, but it does it perfectly. It measures the amount of calcified, hardened plaque in the arteries of your heart. Calcium is a clear marker of plaque that's been there for some time. The test then gives you a number, a score. A score of 0 is fantastic news. It means you have no detectable hard plaque. And that tells us your risk of having a heart attack in the next 5 to 10 years is extremely low. But as that score goes up, from 0 to 100, or to 400, or sometimes even over 1,000, it tells us a very, very different story. I tell my patients to think of the CAC score like a weather forecast for your heart. A score of 0, that's a sunny day with clear blue skies. A high score, that doesn't mean it's raining yet. It doesn't mean a heart attack is guaranteed, but it means there are dark storm clouds gathering on the horizon, and it means we need to be proactive. We need to get out the umbrella and make a plan. And for many people with a high CAC score, even if they've never had a heart attack, that plan absolutely includes a serious conversation about starting aspirin.
A weather forecast for your heart. I love that analogy. It's so clear. It's not a diagnosis, but a risk assessment. Are there other tests that are helpful if a CAC scan isn't available?
Yes. Another excellent, and again, completely non-invasive tool is a CIMT test. That stands for Carotid Intima Media Thickness Test. That sounds complicated, but it's really just a simple ultrasound of the big arteries in your neck, the ones you can feel the pulse in. With this test, the technician can actually use the ultrasound to measure the thickness of the artery wall. If the wall is starting to get thick, it's a very early sign that the process of atherosclerosis, or hardening of the arteries, has already started happening throughout your body. We can sometimes see this even before plaque has hardened enough to show up on a CAC scan. It's another way to get a direct look at the health of your arteries.
So you can literally see the disease starting.
You can. And finally, we can use advanced blood tests to look for the level of inflammation in your body. The most common one is called high-sensitivity C-reactive protein, or HSCRP. Remember our fire analogy? If plaque is the pile of wood, inflammation is the gasoline that gets poured on it. Inflammation is what makes plaque unstable and more likely to rupture. A high HSCRP level tells me that the environment inside a person's arteries is angry and inflamed, and that in itself increases their risk significantly. So you see, Sarah, with these incredible tools, the CAC score, the CIMT, the inflammatory markers, we don't have to guess anymore. We can move from giving general advice to practicing truly personalized medicine. And that is how you make an informed decision about something as powerful as aspirin, not based on a headline, but based on what is actually happening inside your own body.
That makes so much sense, Dr. Miller. Moving from general, one-size-fits-all advice to truly personalized medicine based on real data. So for our viewers who are listening right now and thinking, okay, I want to do this. I don't want to guess anymore. I want to know my real risk. What's next? After someone gets these test results that you've described, what is the action plan? Can you give our audience a clear, step-by-step guide?
Absolutely. And this is the most important part of our conversation, turning this knowledge into action. The plan is actually quite straightforward. I usually break it down into 3 key steps for my patients. Step 1, and this is the foundation of absolutely everything we've talked about, is get tested. Don't guess, measure. I would urge anyone over the age of 50 or 60 who has risk factors like high blood pressure or a family history of heart disease, and who has never had one, to have a serious conversation with their doctor about getting a coronary artery calcium scan, a CAC scan. As I said, it is fast, it is painless, and it is the single best tool we have to cut through all the noise and see what's really there. It changes the entire conversation from what if to what is. You can also ask about the other tests we mentioned, like a CIMT ultrasound or an HSCRP blood test, to get an even fuller picture of your vascular health and inflammation levels.
Okay, so step 1 is to get the data. Get tested. What's step 2?
Step 2 is to talk to your doctor, but with a plan. This is about becoming an empowered patient. Don't just walk into your appointment and vaguely ask, should I be on aspirin? That question is too general. Instead, you walk in with your test results in hand and you change the conversation. You say, doctor, my coronary calcium score came back and it's 300. My HSCRP level is a little high. Based on this new data, can we reevaluate my personal risk of having a heart attack in the next 10 years? And based on that risk, can we create a strategy for me? Does that new strategy include aspirin? Do you see the difference? It becomes a collaborative conversation based on your specific data, not a general guideline. And Sarah, I have to add a very important warning here. It's something I tell my patients all the time. If you are already taking aspirin because your doctor prescribed it to you after a heart attack or a stent, please, I urge you, do not stop taking it suddenly on your own. Stopping aspirin abruptly can cause a temporary rebound effect. It can make your platelets even stickier for a short period of time. which can actually increase your risk of a blood clot. Any change to your aspirin therapy must be done slowly and under medical supervision.
That is such a critical warning. No sudden changes without talking to your doctor. So, we have get tested and talk to your doctor with a plan. What's the third step?
Step 3, and this is the one that aspirin can never ever replace, is to optimize the basics. Aspirin is a powerful tool, but it is not a hall pass to ignore a healthy lifestyle. It's the extinguisher for the fire, but these basics are what can prevent the fire from starting in the first place. And they are what you think they are. If you smoke, quitting is the single fastest and most powerful thing you can do to reduce your clot risk and improve your artery health. Gentle, consistent movement, like a 30-minute walk each day, does wonders for the health of your endothelial lining, the delicate inner wall of your arteries. And of course, a diet that fights inflammation. That means loading up on leafy greens, colorful berries, healthy fats from olive oil and nuts, while at the same time limiting the processed sugars, refined flours, and industrial seed oils that we know fuel inflammation and plaque instability. Aspirin works best when it's part of a team, and a healthy lifestyle is the team captain.
That's a great reminder that these tools work best when they're built on a strong foundation. A question we get a lot from our viewers, doctor, is about natural alternatives. Are there things like fish oil or other supplements that can do the same job as aspirin?
That's a very common and very important question. And the answer is yes and no. There are several natural substances. High-dose omega-3 fish oil is a great example, and others like nattokinase that do have proven anti-inflammatory and mild blood-thinning properties. They can be very useful tools in our overall toolkit for promoting heart health. However, and this is a very big however, they are not direct one-to-one replacements for aspirin in a high-risk situation. Aspirin's specific mechanism for powerfully inhibiting platelets during an acute event, that is incredibly well-studied and very potent. So natural alternatives can be a fantastic part of a primary prevention strategy for someone with low to moderate risk. They can be a great adjunct therapy, but if you have a high CAC score, or you have already had a heart attack, you cannot simply swap your prescribed aspirin for a supplement and expect the same level of powerful protection against a clot. Again, this must be part of that personalized, data-driven conversation with your doctor. You have to match the power of the tool to the size of the risk.
Dr. Miller, thank you so much for clarifying that. It really underscores the main theme of our entire conversation today, which is that there are no simple, one-size-fits-all answers when it comes to protecting our hearts. This has been such a journey. We've learned that most heart attacks aren't the slow clogs we imagined, but sudden, violent car crashes inside our arteries. We've learned that aspirin isn't a daily vitamin for everyone, but a powerful fire extinguisher that needs to be used in the right situation. And most importantly, we've learned that we can't just rely on how we feel. We have to rely on real data from tests like the CAC scan to know our true personal risk.
Exactly, Sarah. And if there is one message I want every single person watching this to take away, it is this. The single most dangerous thing you can do for your heart is to guess. To assume you're low risk just because you don't have symptoms. To assume a headline applies to you. To assume what worked for your neighbor will work for you. Remember the story about Frank? He felt fine. He thought he was making a healthy choice, but his arteries were telling a very different story. The goal of modern preventive cardiology isn't just to treat a heart attack after it strikes. It's to get the information we need to prevent that catastrophe from ever happening in the first place. Heart attacks don't wait for you to be ready. They don't care about your retirement plans or the family wedding next year. They often strike silently. But prevention doesn't have to be silent. It can be loud, it can be proactive, and it must be informed.
That's a very powerful call to action. Do you have one last piece of advice for our audience as they move forward with this new and potentially life-saving knowledge?
I do. I want everyone to see this information not as something to be scared of, but as something to be empowered by. Taking control of your own health data, knowing your CAC score, understanding your inflammation levels. This is the new frontier of senior heart health. It's about moving from being a passive patient to being the CEO of your own health. So my challenge to everyone watching is this. Don't let another year go by flying blind. Make the call. Ask your doctor about the tests we discussed. A proactive conversation with your doctor today is one of the greatest investments you can make in your long-term senior heart health. Please don't look at this as just another doctor's visit. See it as one of the most powerful, proactive things you can do for your body. Taking these steps is how you truly protect your future, and it is the most important commitment you can make to your senior heart health.
From confusion to clarity. That's the real gift you've given us today, Dr. Miller. Thank you so much for making such a complex topic so understandable and for providing such a clear path forward. And thank you to our incredible Health Voices community for joining us. We hope this conversation has armed you with the information you need to have a more productive conversation with your doctor. What is the one step you'll take after watching this video? Will you be asking about a CAC scan? Let us know in the comments below. Your story might be the motivation someone else needs to take that step. Please, share this video with anyone in your life who you know is confused about aspirin. You could be sharing truly life-saving information. And don't forget to like and subscribe for more conversations that cut through the noise and get to the truth. Until next time, be well and take great care of your heart.